My name is Sue Doherty. I work for Serving Our Seniors, and we advocate for the rights of people 60 and better to maintain their independence. And I got to tell you, I am very grateful to all of you for wanting to be engaged in understanding how our healthcare system is evolving. There's nothing more complicated than healthcare and insurance, and we're trying to understand both. So I really appreciate your interest in being informed and savvy consumers, and we've got a whole lot to learn. We've got 2 hours to do it in. And let me begin with some housekeeping. If anybody has a cell phone, would you please do me the favor of turning it off or turning it on vibrate? And for those of you who are not aware, the restrooms are out the hallway and go to your left. And let me see. And just to let you know, we did, I was really pleased. We had 500 RSVPs, and we have 500 seats, so not everybody attended. But I must tell you that I'm very grateful for the response that we've had from our community on this issue. The scope of this forum is going to be restricted to just Medicare consumers and Medicaid consumers. In February, when we held our forum, we were not able to answer any Medicaid questions. Today we are. The one thing that we will not talk about are the healthcare exchanges. So if there is anybody here who is under the age of 65 and seeking opportunities to buy healthcare coverage through the exchange, we do not have anybody on the panel with that area of expertise. But I am working to pull that together for October. So at this time, what I'd like to do is introduce to you my co-facilitator, Matt Westerhold. He's to my right. And I'd like to thank the Sandusky Register for all of their help and their support in making this forum public and known to the community. The Sandusky Register has been very supportive of the work of Serving Our Seniors, and I'm very grateful. Thank you, Matt. On our panel, we really do have a terrific panel here this morning, and they've traveled as far as Columbus and Cleveland and Toledo. So to all of the panel, I want to thank you very much for making the time and the effort to be here, including those of you who have traveled locally. Let me begin with introductions to my far right. David Painter is with the Ohio Department of Insurance, and he works for a division of that department called OSHIP with a P. And what they do is they are consumer advocates. They want you as Medicare consumers to understand your health insurance. They do not sell insurance. They don't make a commission. They're purely to educate consumers so that they understand the coverage that they have. David, thank you for being on the panel. Next to David is John McCarthy. He's the director of Ohio Medicaid. So if there is anybody that has a question, because there are individuals who are on Medicare and they also receive Medicaid. And so if you use Medicaid insurance, John is the authority and can speak to questions as it relates to Ohio Medicaid consumers, and he traveled from Columbus. John, thank you very much. And it's a pleasure to have with us our Ohio Senator Randy Gardner, who's also on the HealthCare Committee in the state legislature. And Randy, he lives in Bowling Green, so I don't know if you traveled from Columbus or Bowling Green today. Bowling Green, thank you for making the trip, and it's a pleasure to have you on the panel. Next to Randy is Wes Farbach, and he is the staff member from U.S. Senator Rob Portman's office. He traveled from Toledo, and Wes was also here on the last forum, so you may remember him from February. And Wes, thank you for making the trip and being available. Next to Wes is Sue Rowe. She is the staff member from U.S. Congresswoman Marcy Kaptur's office, and Sue was also on the panel at February's forum when we were talking strictly about Medicare, and she too traveled from Toledo. Sue, thank you. Next to Sue is Kim Storms. Kim works for an organization called Ohio KeyPro, And the work that they do is to monitor to make sure that Medicare consumers receive quality care. So if any of you have questions as it relates to health care reform, and I know the feedback I'm getting from senior citizens is they are concerned that they will get worse care or less care with health care reform and being on Medicare. And Kim is on the panel and can speak to those issues too. Kim, she traveled from Cleveland. Thank you for being here. Next to Kim is Rob Moore. He is with Firelands Regional Medical Center, Vice President of General Counsel. And Rob spoke at our last forum, and I believe everybody found him extremely informative. And Rob, thank you so much for making the time to be here. And last but certainly not least is Jane Arnold, also a Vice President with Firelands Regional Medical Center and also a wealth of information. So Jane, thank you for your time and your commitment to be on the panel. And I'm ready to start a good dialogue between senior citizen consumers and our panel of experts. So let me remind you that we don't have anybody on the panel who can speak to the exchanges, so it's strictly as it relates to your coverage under Medicare and Medicaid. Okay, who would like to begin? And if you don't have any questions, I'm happy to get it started. Okay, to the panel. Is there anybody on the panel who can explain for us how healthcare is going to be rolling out? So I know it's not one fell swoop. So what is it that we will see in 2014 that that is just the beginning of healthcare reform? Can any of you give us one example of what's going to change? John.
Good morning, everyone. I'm John McCarthy. I'm the Medicaid Director for the state of Ohio, and I'm glad to be here. We're always looking for chances to get out and talk to people about the great work that we're doing and trying to reform the program, make the program more efficient and better. One of the big changes coming to the state of Ohio is an initiative that we are working with Medicare on. In the Affordable Care Act, there was a provision that created the Centers for Medicare and Medicaid Innovation. And as a part of that, there was something to integrate the care between individuals who are enrolled in both Medicare and Medicaid. So those are often referred to as individuals who are dual enrolled. Not in this budget that just passed in the state of Ohio, but actually the budget previous to that, so the first case of administration budget, we have proposed to move forward with the federal government to put in an application to integrate care between Medicare and Medicaid. We were actually the third state in the union to actually receive an MOU, a Memorandum of Understanding, with Medicare to create such a program. So originally we were calling it the Integrated Care Delivery System, ICDS. That's, we were trying to come up with some name for it. But then what we ended up, the new name is MyCare Ohio that we're going to be rolling out. The launch date for that is March of 2014, so that's coming up here. And again, it's for individuals who are dually enrolled in both Medicare and Medicaid. And we selected certain counties throughout the state of Ohio to bring this program forward. We've been working very, very closely with Medicare to create the program, because one of the things that we saw, and you're going to be like, well, why did you guys do this? Governor Kasich is very concerned about, obviously, the Medicaid budget, but more importantly, he is concerned with making sure people get the care they need. When we looked at our data for individuals who are dually enrolled in both programs, while they made up a small percentage of the program, the expenditures associated with them were extremely high. So it's around 37 and 39% of our expenditures. And when we got into the data and started looking at the data, what we noticed was a lot of care that was being provided, so people were getting care, but it was care that was not necessarily in the best setting or best integrated. And so one of the things that people often forget about, and especially when you're on the inside, is when you're on the outside looking in, how are decisions made? They're two very complicated programs. Medicare is complicated and Medicaid's complicated. Then you stick the two together, right? And it gets even more complicated from there. And what we noticed was people weren't necessarily making decisions for themselves, and who was making the decision was your provider. And the provider was making a choice of health care not based on what you needed, but based on what the rules of each program was and what they would pay for. So what we wanted to do is, how do we break down those rules to make sure that people get what they need, not what each program would pay for? So when we went forward with this, the way the program works is the two programs will be working together hand in hand. It goes live March 1st, and people who are duly enrolled in both programs all the time will be getting a welcome packet and a letter, along with, we are also investing in, we're working with OSHIP, the local AAA, and a number of other entities to be able to come out and explain the program face to face. So there's a person to talk to about it. And you'll be getting a welcome pack which will say, individuals will be getting a welcome pack that will say, welcome to the program, here is what we can do for you. And what we're asking individuals is choose between one of our two partners in the program of where you'll be getting your care from. And so it's kind of a different model of care that we're looking at to integrate the care. Now, in doing this, we were very concerned about individuals, and I actually personally held public meetings and went to a number of public meetings. I didn't make it up here for one, but my staff, Harry Sachs, and some of my other staff did make it out around parts of the state, but I was in 3 of the public meetings, and we got a lot of feedback from people. And the number one thing we heard from people was, we want to keep our providers. John, if I have to keep my doctor, my hospital, and those different pieces. We totally agree with that, and we understood that. So what we did is, when we created the program, that for all individuals that are that decide to stay in the program, because you always have the option to opt out of the program on the Medicare side, that if you remain in, that whichever one of the partners that you choose that we are working with, you have to be able to keep your provider for the first year. So for 1 year, your provider has to get paid at the rates that they're getting paid. You get to keep your provider. Any prior authorizations that are there or anything else, you would get to keep those things.
So John, can I interrupt you? What's the name of the program again that they'll be getting literature in the mail? It's called Ohio?
My Care Ohio.
My Care Ohio.
Yes.
So if you get that information in the mail, the one fear that you can dispel is that they do get to keep their doctor, their hospital. Okay, even though they're being,
that you have.
Okay, thank you.
Yes, that you currently have.
For 1 year and beyond that, then?
Hold on, let me finish, and so I can pull it together. There's one exception to that. For individuals who are in a nursing home or in a assisted living setting, for those individuals, you get to keep your provider. It's a demonstration project that we're doing with Medicare. So for the entire 3 years, you're able to stay where you're at. We don't want people to have to move out of nursing homes or assisted living. You get to keep your providers there. Additionally, we worked with the AAAs. And
AAA means?
The Area Agency on Aging. They are our partners in a number of different ways, us and the Department of Aging, but they do the administrative side of our Passport program, which is our waiver program that provides home and community-based care. So for individuals who need help and they want to stay at home as opposed to going into a nursing home, that's where that home and community-based care comes from, is through the Passport waiver and the local AAA.
And Medicaid pays for that.
That's all Medicaid. That is not Medicare. It is Medicaid. So the AAA, by mandate, has to be the provider of service and care manager for services for individuals. So that doesn't change either. So now let's go back to the 1 year question on other providers. This is kind of what we were running into. On any time you're bringing up a new program, and we're using a managed care model, so we're working with plans on doing this. The issue came up of, do we mandate them to contract with providers? And one of the issues was just a timing issue, that there's not enough time to make sure the contracts were all in there. And also the other issue that came up is quality of providers. And so what we said was, for 1 year, there's a guarantee on this. But during that year, we're also looking at the plans. The plans are reaching out, making sure they're getting contracts with providers. And what we've seen, and as the plans have been putting together their networks, most all providers are entering into contracts, or they're already in contracts with the plans. And so for most individuals and most providers, they're going to just continue to be, their providers are not going to change.
But this is one of the things that came up in our public meetings, and a number of people brought this issue up to me. And so I want everyone, if you have a primary care physician, raise your hand. Okay, so now how many of you in the room have the primary care physician who's the bad primary care physician, below the 50th percentile? Okay, so this is what I've learned in the state of Ohio. All of our physicians are the best there are. There are no bad physicians in the state of Ohio, is what I've learned. I use that one because everyone's got a primary care physician, but I'm not picking on primary care physicians. It goes to home health aides, and if you're using home health personal care aides, it's the same question that comes up. And I will tell you this, and I have a difficult job, right? It is not easy to have my job, but one of the things that we are trying to do is improve quality. And when we look out and we look at all the providers we pay for and all the services we pay for, we do see a different level of quality across providers. And I'll focus on home health right now, because that's where one of the areas where I think there could be improvements quite a bit. Is when you look at that and you have a home health care agency helping you out, what we see is some good providers and some bad providers. But often, many of you who are out there don't know if it's a good or bad provider. There's no metrics out there. There's nothing that you can see. And what you're hearing usually is word of mouth. Somebody tells you, a provider refers you. And I will tell you, just because a provider refers you to somebody else doesn't always mean that that's a good relationship there. There's all kinds of interesting things that can happen in the background. So what we were saying is, in Medicaid right now, in our fee-for-service program, which is for all individuals we're talking about, in our fee-for-service program, we really don't have good quality control mechanisms in there to keep bad providers out or good providers and good measures. We're working on it. That is one of the things we're working to. But one of the issues is with our managed care partners is developing those quality metrics to be able to use those to present information back to individuals like yourselves that say, here's the high-quality providers. Here's the ones who are providing, we have the best health outcomes. Because what we're always trying to do is improve health outcomes. And what we see is those providers, especially home health care providers, who are providing the best outcomes, those individuals have the best health outcomes.
Okay, John, let me interrupt. So for these changes in Medicaid, again, the name is called?
MyCare Ohio.
MyCare Ohio. And is it going to be rolling out in Erie County in March? Or is it going to be at a different, is it going to be all of the state of Ohio? Or is it going to be only in certain parts of Ohio?
There are 27 counties that we're rolling it out in.
Okay, so
it's a phased-in approach, but in March.
Okay.
In March is when we start voluntary enrollment.
Even in Erie County?
Yes. So across the state, for all the 27 counties where we have My Ohio Care starting, people will be getting, and you're duly enrolled. You have to be enrolled in both programs.
Okay. You
will be getting a packet that says, welcome to the program. Who would you like to, here's the information, people you can contact to get more information. And then additionally, it'll say who the managed care partners are in this area.
Okay.
And then Erie County's ultimate enrollment is, I think, on the back end. So it'll be March, April, May, June is when it.
So what you're talking about will affect those who use Medicare and Medicaid. What's the income criteria to qualify for Medicaid if you live in the community?
Okay, so this one is obviously, this is where I'm saying it's complicated, right? So right now,
just a rough ballpark, because don't get into too much detail, because I want to move on to other topics.
Yes, for most, and it's even a little bit of detail is always difficult in Medicaid. It's basically, the numbers is about, if you're at 64% of the federal poverty level, which you're earning, if I'm doing the calculation right at the top of my head, about $8,000 a year is where you're at, a little under $8,000 a year. Now,
so what you're talking about would
hold on.
Okay.
But there's also individuals where we go up to, if you're in our waiver or nursing home, 50% of the federal poverty level, which is like $25,000 or so a year. So it's kind of a different area in between there.
Okay.
And that's for individuals, let me clarify one other thing, for who are both Medicare and Medicaid beneficiaries. So you actually are getting Medicaid benefits. So if you're in the Passport program, some people don't realize this, if you're in the Passport program, that is Medicaid. So you are on Medicaid, and so you would be one of the individuals that we're talking about. If you're an individual, though, where we're just paying, where Medicaid is just paying your Part B premiums through the Qualified Medicare Beneficiary Program, that is not, you would not be in this program. So it's the
Okay.
people who are fully enrolled in the Medicaid program, which is basically if they're in the Passport program, that would be one of the details.
Okay, so if we could move on to another, great information. I don't know how many people in the audience fall in that income bracket, but if that describes you, you would want to listen to anything that's set up here that as it relates to Medicare and Medicaid. So, okay, here's a question.
Yes, you were, I guess you can hear me. You were talking about the outcomes, I guess that's the word you were using. I spoke with a physician to give me an example and see if this fits. He was telling me, for example, there's a couple that would come to him that were diabetic. So he would offer them the prescriptions, tell them the diets they were supposed to go on, et cetera, et cetera. And this couple would go out, not take their prescriptions, not eat like they were supposed to, and they would come back for their next checkup, and of course the checkup would be awful. Now because of that, he might be denied payment. Is that true?
So in the Medicaid program, that is not true. That is not true that he would be denied payment. Actually, we took a very different approach to this. This is currently happening in our current managed care contracts for individuals in the program, is that we do something called care management. We pay the managed care plans to do care management. And the Medicaid program used to have a requirement that anybody, it was about 10% of the population had care managers to come out and talk to them. So when I came into office 2 years ago, I showed up and said, well, how are we doing? Poor health outcomes, nothing really going on. Care management was being done by the phone. I'm sure some of you get the call from the nurse who you've never talked to before in your life, right? That says, oh, are you taking your drugs? Are you doing this? That doesn't work. It doesn't work for me. We're dealing with the same healthcare issues in my family that you are, right? So I'm like, this doesn't work. So what did I do? In our current managed care contracts that went into effect last year, with our managed care plans, we said 1%, we're going to take the top 1% of the people, the sickest people, and you have to have face-to-face contact with the individual. You have to get out into their homes, and the case ratios can't be greater than 1 to 25. My managed care plans were like, no, John, that's not going to work. They're complaining, blah, blah, blah. And I said, no, we're doing it. And we did it, and guess what? They all have reported that with that care management, people getting out into people's homes, they have seen reductions of 50% of ER usage and hospitalizations. And what is it when they come out and talk to a person like you were talking about? Many people want to do the right thing, right? But there's other stuff going on in their lives, And so the number one issue that they see is food issues. And the food issues are one of two. Number one is you go look in the fridge and there's no food in the fridge, and the person doesn't know about a food bank or something like that. Or number two, they're diabetic and you look in the fridge and it's all the wrong food, right? And so then they're working with the person then to hook them up with a nutritionist to make sure that they get the right food. And they've seen huge improvements for those things. And so we're not putting the penalty on the physician for that. That's not something that we're saying that we're doing right now. Now, at some point, the physician needs to be held accountable for other decisions they're making, like is it the right drugs, are they giving the right tests and things like that. But we're looking at it as a team approach and everyone working together on this. And so we've separated those things on the Medicaid side to make sure that what you said doesn't happen. Because in the Medicaid program, and we actually have a meeting with physicians going today, we need physicians, right? We need physicians. They're the backbone of the program. So I am working with physicians every chance I can to improve the program, make their lives easier, and at the same time hold them accountable. So that's one of the things.
So that's for Medicaid, but what about for Medicare? Who can speak to, will physicians not get paid if their patient is not compliant?
What your physician was talking about was something called pay for performance, and it is threatened all the time whenever there's Medicare changes. It has not yet been implemented, and so the first thing that physicians think of is patient noncompliance. But what pay for performance really is what John spoke to. Are they giving appropriate testing in the appropriate settings and the appropriate medications?
So in answer to his question, if I am a patient that doesn't fill my insulin prescription and I don't eat my diet, what happens to my doctor, and will my doctor go out of business because he has too many of these types of patients?
Your doctor will still be paid for the work that he does, for your visits, for your hospitalization all that, he will still get paid.
Can a doctor discharge, and this is open to anybody, if a doctor's status with his reimbursement provider is dependent on patients being compliant, can a doctor discharge caring for a patient?
I can handle that one. Yes, they can.
Okay.
They have to provide under the guidelines from the state and the state medical board. They have to provide a minimum of 30-day notice, and in turn setting forth the reason for the discharge. In the 30 days, the physician has a responsibility to be sure that that patient has adequate other alternative care, specifically being directed to go to the local ER, if necessary, other providers that may be. So there is an affirmative obligation on the part of that physician or that practice to be sure that that patient isn't, quote, abandoned. So, but they can discharge. Okay. So, and I think on the other point, at Firelands, there is no penalty. But so I think the goal in the Affordable Care Act is it's really to incentivize and to encourage really more healthy behavior. We have now physicians can be reimbursed for those wellness, annual wellness checks. And so again, the idea is not to penalize the patient, but to encourage the patient and through counseling and help and support is to look for those maybe healthier lifestyle changes and things along those lines. So again, there is no penalty and no one gets summarily dismissed.
Well, and I think that because the question that you just heard from this gentleman up here are the kinds of questions that we hear at our agency, and David, you probably hear them too. I can tell you what that means for Erie County. If any of you were to experience being discharged by your physician saying you have 30 days to find another place, we are really fortunate in Erie County because if you cannot find another private practice, in Erie County there are 2 family practice clinics, and one is at the South Campus of Firelands Regional Medical Center, and it's called Family Health Services of Erie County, and the Erie County Health Department also has primary care. And so if that non-compliance issue ever comes up and your physician says that I'm going to have to let you go because of health care reform, please know that that is a skewed way of saying I'm blaming it on health care, I'm not blaming it on your non-compliance. But even if that does happen, you've got 2 choices in Erie County if any other family practice physician decides not to provide your care. So that's an important piece. And are there any other questions? David, I emailed one to you. It was about being 72 or 75, and at that age, I'm not entitled to a particular type of care under Medicare. Could you address that?
Yeah, it had to do with, and some of you have probably seen this in your email, and Sue had sent that out and saying, here's some of the things we're getting. And it's just some of the rumors that are going around on email about the Affordable Care Act. And basically, just to see if any of you actually have gotten this, it was supposedly reported to a Judge Kithel or something like that, who supposedly went through the CARE Act and pulled out all these different lines and said, well, here it says that we can start rationing out cancer care and we can ration out this and we can stop this and that and the other. And it's gone around literally millions of people have gotten these emails. So when Sue sent it to me, it wasn't the first time I'd ever seen it. And she asked if it'd be something we would address, and I said absolutely, but I sent her the email back and said, just so you know, the specific information they're pulling out there, one of them is that you can't get cancer care, I want to say it's after 72 or something like that. That refers to a different bill. It refers to a bill, and I want to say it was, I'm really bad with the numbers, but that was a House bill, maybe 3200, something along those lines, which was defeated. There's not the Affordable Care Act, which was actually what was passed. So and the only reason I throw that out is I just want to caution folks, when you get something like that through the internet, don't immediately say, oh my God, call the newspaper and say, hey, you need to print my letter, everybody needs to know this, we got to get the word out. I kind of look back, there's a commercial out right now where there's a woman who says everything you hear on the internet has to be true. And she says, she has a date and it's a French model. Have you seen this one? The guy shows up and he's like, bonjour. That's kind of how the internet goes. If you do hear one of these sort of rumors, you want to know what the heck's going on, everybody should have got a bag that has our 800 number on it. That's us, OSHIP, 1-800-686-1578. In there, you're also going to have a notepad that has our 800 number on one side. We're staffed 8 to 5. The flip side has Medicare, 1-800-MEDICARE, which is 24 hours a day. If you can't find either of those, give Serving Our Seniors a call. You have a lot of resources, before you, hit the panic button, something like that. Even if we're here today and you're like, you know what, when you get home, it's like, you know what, I wanted to ask such and such, but they ran out of time or I forgot to do it. Don't leave here today thinking, well, that was my one and only shot to get this stuff answered.
Okay, question
And
over here.
another good source of information, if you're a person who likes to be on the internet and checking these things out, is a website called factcheck.org. So if you go to factcheck.org and type in a question, it will tell you, and plus actually it has a lot of information to begin with. A lot of these hot button things that keep circulating are right on the homepage of factcheck.org. So always, anything you get on the internet, you can check and see if it's factual through that website.
FACT, fact check. Okay.
Question. Earlier, somebody mentioned if you're on Medicare and you're only Part B, that you're not enrolled in the Ohio or My Ohio Care. I mean, if your card says A and B, is that the same situation? And in that,
Medicaid.
oh, Medicaid.
Yeah.
Okay.
So again, I know this is
separate things.
complicated.
Right.
And from our standpoints, right, Medicare, Medicaid, oh yeah, totally different, but it's the words are similar and everything else. The MyCare Ohio program is for individuals who are fully enrolled in Medicare, so you're enrolled in Medicare Part A, Part B, and Part D, and in addition to that, you're fully enrolled in the Medicaid program. So you would have two different cards. You would have the Medicare card plus the Medicaid card. And so what we have found, though, is that some individuals actually don't even realize they're enrolled in Medicaid, specifically individuals who are enrolled in the Passport program. They say, oh, I'm not on Medicaid, I'm just on Passport. Well, Passport actually is a Medicaid program, and so I was just using that as an example in there.
Okay, question here.
I understand that with the Medicare and the Affordable Care Act that there's lots of things that are no charge to seniors. And I would like to know where we find that out so that we can take advantage of that.
There you go. That's good. And he should already know the answer to this because he's seen me talk before. I recognize you. He's asking the question for all you guys. He already knows this. There are a number of things that are in there that are just free preventative benefits. Some of them actually predate the Affordable Care Act, but there's a number of things in there. A number of screenings. I don't know if any of you have taken advantage or you're welcome to Medicare exam. There's also an annual wellness exam, and it's a free trip to the doctor. It's not a full physical, but there's also a number of screenings: bone mass density, diabetes screenings, different things like that. Flu shots, pneumonia shots. They should both, they're also preventative benefits at no charge to folks. If you're getting it through the doctor can charge you an office visit, but they shouldn't be charging you for the flu shot if you're on Medicare. And ways to find out about it, there's a couple of different ways. There's a website called mymedicare.gov, and if you just go to medicare.gov, you can get to mymedicare.gov from there. You can get a username and password, and you can use that site a couple different ways. For one thing, you're going to see your Medicare summary notice a lot quicker on there. Meaning, for those of you who are on original Medicaid, meaning not on an Advantage plan, I'm still on my original A and B, I haven't signed up for an Advantage plan, you should be getting...
David, you said Medicaid, so just to clarify.
Did I?
Yeah, so go ahead. So he's talking about Medicare with an R. Okay, go ahead.
I work for OSHIP, right? Okay. Medicare. So on mymedicare.gov, you can see your charges a lot quicker, meaning with the Medicare summary notice, quarterly I'm going to get that and it's going to say, here's the doctors I've seen. And the purpose of that statement is to look back to say, yeah, I actually did see Dr. Smith and that should be charged, and to look for something like that. Well, one thing you can do on mymedicare.gov is see a lot quicker how, when you've been to that doctor. It shows up about 2 weeks later. The other thing that website's going to do is send you reminders of when you're eligible for these free services. And it'll say, hey, Dave, as of August 1st, you're eligible for a diabetes screening. Maybe I should take advantage of that. If you're not computer savvy, if you're not interested in doing it, give 1-800-MEDICARE a call. Your doctor, they'll always say, hey, your doctor keeps track of that. I'm not going to give your doctor that much credit to say that they're able to keep track of that for you. But there's ways to find out about it. There's a few different ways to find out about it.
And is that because of the Affordable Care Act, or that was in place even without?
Some of them were in place before, but it's definitely been expanded with the Affordable Care Act. There's a lot more preventative benefits with the Affordable Care Act.
And let me say, for those of you who are not comfortable using a computer, if you're willing to come to our office and let us do it for you, that is a service we can do on our computer, but it does mean inputting personal information about you into the Medicare website. So if you're comfortable doing that, we can do that for you.
Well, let me be real clear on that, though. Let me actually correct you on that.
Okay.
When she says inputting personal information into the Medicare website, that to me sounds like they're taking my personal information and putting it into the Medicare website. You're already in the Medicare website. What she would be doing is taking your personal information to look you up in the website.
Thank you.
It's not like your information's not there. If you have Medicare, your information is in that website.
Thank you for that clarification. Matt, do you have a question? Okay, I have one here.
Okay.
Along the lines of getting information that you don't know is something you're supposed to believe or not believe, it's my understanding with HealthCare, there's a group of people in Washington, D.C. that's going to say, yes, you can get that particular medical service, or no, you're not. I mean, is there any truth to this?
Good question. Thank you for asking. That's what I hear a lot also.
The answer is no. This gets back at this issue of people deciding, some people call it the death panels, people deciding whether you're going to get health care or not. I don't think we can say it often enough. There's no such thing as death panels. There's no such thing as people deciding whether you're going to get health care or not. If you and your doctor and your family decide that a particular surgery or treatment is best for you, there's nobody that's going to say, no, you can't have that surgery or treatment or whatever. What this twisting of is that the right now, or for years actually, hospitals often have on staff medical ethicists. They have social workers who are trained in dealing with people, families who are facing a critical situation, and people might choose a consultation with a medical ethicist, a team of people at the hospital, including a person's own physician, and previously that had not been always paid for under people's insurances or Medicare. Now, the Affordable Care Act says that consultation is a covered service. That's all. That's all this ever started out to be. But somehow along the line, it got twisted to mean these death panels, and that does not exist.
So Sue, let me paraphrase, and I would like every panelist, because we have a full spectrum of people, both Medicare and Medicaid. So David, in your education and training as a counselor about healthcare coverage, would you agree that there is no such thing as a death panel?
I would absolutely agree with that, yes.
Okay, John, in Medicaid, would you, because this really is a fear, and so I want to be very clear on this. Is there any reason for concern in Medicaid about death panels?
We do not have death panels in Medicaid.
Okay, and Senator Gardner?
Well, since this is my first time to speak, I want everybody to know that I'm excited that I'm 5 years away from being eligible to move to Erie County and be taken care of by Sue Doherty and her program. I used to not like that, but seriously, no county this size in the state does this, and does this so well. I mean, it's just. I learned that with the Affordable Medications Program years and years ago, and it continues today. I'm going to say it a little different. I think the Affordable Care Act was one of the most significant transfers of power to bureaucrats in Washington in the history of the country. And I think there are certainly some well-intended goals and potentially some well-intended outcomes that may result from it. And I think there's a lot of questions that continually are asked and answers that seem to change as the program evolves. So I definitely support the views of the other two panelists regarding the so-called death panels themselves. But I do think in terms of the questions of keeping your own doctor and how that evolves and how these plans are going to emerge and how exchanges or not will affect individuals, I think a lot of those questions are not necessarily absolutely 100% answerable today because of an evolving bureaucracy and decisions made by federal departments in Washington. So the answer to that question specifically, no problem with me there, but I think some other issues are evolving, and organizations like this should very much stay involved in getting answers as you move through the program.
Thank you, and we will. And you've raised some good points that I'd like to get back to as soon as we hear from Senator Portman's office.
Thank you, Sue. I also would agree with what Randy said. I work in 19 counties in Northwest Ohio, and Erie County does the best job and probably the only job in addressing a lot of these issues. So thank you, Sue, for your leadership and your program here. I would also agree on the issue of the panels, and a lot of that came out from the internet, and as was addressed earlier, the two allegations that Sue had sent us to look at are our lead medical legislative person in Washington happens to be a doctor and actually a neurosurgeon who got tired of surgery and taking a few years off to work on policy and implementation. And so Dr. Joe knows all of this from the practitioner's side, and then also advising patients, and he completely agrees that the allegations that were floated around the internet are not accurate. But I think at the same time, as Randy said, one of the things that Senator Portman spoke on just about a month ago is the tremendous increase in healthcare costs that all levels of government and individuals are going to have to address over the next decade and so forth. And it's become a major part of all state budgets, probably about 40% in the state of Ohio's case. That was the number when I worked for the state that was tossed around. And it continues to grow, and that's going to have an impact on you, your kids, and your grandchildren. One piece of, most of what we're talking about here today is policies that are being implemented and developed. I wanted to call your attention to one bill that there's a bipartisan, bicameral bill that Senator Portman has introduced with Senator Wyden from Oregon, and on the House side with Congresswoman Fudge from Cleveland, and it's a healthy seniors bill that would, between the patient and the doctor, develop a list of goals of what you could do to make yourself more healthy, and as a result save costs to the program. And it's actually, as developed, if you met the goals, it has a financial reward for both the doctor and the patient, which is kind of an unusual proposal, but it says if you help save money, you can, and the number in my notes on the BlackBerry said it could be up to $200 per year. But it's part of a direction that all people, whether you're a service provider like the doctors in the hospitals or the governmental side in running this, or legislators that the three of us here represent, it's a concern and something we all will continue to work on and try to provide the best programs and services for our citizens, especially senior citizens. And Randy, I'm a couple years closer, I think, to being eligible to come to Sue's program, so, and I'll pass it over to Sue here.
But in a nutshell, you said no death panels. Okay, thank you. And Kim?
No death panels from Medicare.
Okay. And
just on behalf of the hospital, again, there is no rationing. There are definitely no death panels. And something else, while there are a lot of arguably bureaucratic and government involvement, I mean, that's just the nature of the beast. But at the same time, as individuals, you have a lot of advocates and you have a lot of control. And so, first of all, at Firelands, if you have questions, we have patient advocates, we have case managers you can call. We will move heaven and earth to get everything resolved. In addition, you can call our friends at KeyPro, and we talk to them. And so in turn, you will not be summarily discharged. Again, your care will not be rationed. And on top of that, on behalf of the hospital, we're looking to actually not have you readmitted. So we want to be sure we get it right the first time. And so we want you to be healthy. We want you to have a good discharge plan so that you can go back, whether it's home or wherever, and not be readmitted back to our emergency room. And of course, our emergency room is always open 24 hours a day, 7 days a week, 365, and you walk in, we'll take care of you. So again, that's always just one of those fundamental, kind of building blocks of our community. So there is no rationing at Firelands, and you have lots of advocates at KeyPro at Firelands. So.
And for me too, no death benefit. We do want to make sure though, medical necessity and death benefit are two different things, and we'll do whatever it takes to, if you have a test that a physician orders, we check medical necessity on those. We will help you as a Medicare beneficiary get medical necessity for that, and if it's something we don't agree on or your physician doesn't agree on, we can also appeal that with Medicare with some additional information from your physician. So we'll do what it takes to get your coverage.
Okay.
All right.
Matt, did you have a question?
A question here.
I'd like to know if you have a question with a medical issue, would Medicare cover a second opinion?
Oh, with healthcare reform, are they stopping second opinions, or can you continue to go to another doctor just as you could before?
No, they're not stopping the second opinion, and you can get a second opinion from another physician, and that should be covered by Medicare.
Okay, over here, look to your left. There I am. You guys, you talked a little bit about the free services and stuff like that. To me, what it comes down to is, what's my monthly cost for my health care insurance? What's my monthly cost for my prescription drug? What does it cover? The deductible. What's going to be my deductible, and what's going to be my maximum out-of-pocket? And I'm thinking 2014, 2015, when we come into the Affordable Care, we're talking dollars and cents, and those are the things that I want to know, and where can I find that?
Great question. So what's it going to, how is the Affordable Care Act going to change what I'm paying out of pocket?
Well, one thing that it's going to change, and has already been changing in your out-of-pocket expenses, is with your Part D coverage. Anyone who has Medicare Part D to cover their prescriptions, the initial deductible is going to go down to $310 next year, and the so-called donut hole, which is the gap in coverage, is shrinking every year. I think it's going to be $2,700 and some next year. Don't quote me on the amount, but it's going down. I think it's $2,700 and some. So that gap between when the Part D private drug plan is paying a portion of your drugs, and then it stops, and then when you get to the other side, it picks it back up again. A lot of people fall into that gap and can't get out because they can't afford to pay that coverage. So the drugs in that gap, when you're paying 100% of the cost yourself, are reduced by half if they're brand name, and a lesser amount if they're generic. And the gap is smaller. And every year that will continue until 2020, when that gap will close completely. So that's on the Part D side. I don't actually know what the 2014 Medicare premium is going to be yet. Does somebody know that yet? It's too early.
Find that out on Medicare.gov.
Yeah. It may be a little early yet, but you'll eventually be able to find that on Medicare.gov. So I'm not sure what the Part B premium is going to be. Because of the pre-existing conditions, and actually I have a list. Depending on if you're a man or a woman, there's as many as 22 preventive services that are covered at 100%. So things like colorectal screening, mammograms, lots of things are covered so that your out-of-pocket expenses in that regard will be reduced as well. If you have Medicare supplemental insurance, I don't know what's going to happen in terms of the premiums for those. I mean, that's a business decision that those insurance companies are allowed to make. However, Medicare Advantage plans have to pay, and eventually all insurance, you have to follow what's called the 80-20 rule. So if your insurance plan is not providing 80 cents of health care, or 80 cents towards your health care expenses of every dollar, so only 20 cents on the dollar can be used toward administrative costs. If they're not meeting that 80 cents on the dollar toward health care, they have to reimburse you that money. So people are getting checks back in the mail from your insurance companies if in fact they're not meeting those goals.
Has anybody received a check back? I'm just curious, because that actually started in 2013, right. Didn't it? Right. So has anybody received a check back from their insurance company? So you're a company. Okay, great. So and that was because of the Affordable Care Act?
Right.
Okay. So, okay, you told us the good news. Is there any bad news about cost that we ought to be prepared for?
I don't know that I can actually answer that.
Okay.
I'm not.
And I really appreciate that. If you don't know the answer and the information's not to you, please don't feel bad about saying, I don't have the answer to that. But if you do, is there any discussion on the premiums not going up? Has there?
Some states, and I'll defer to Senator Gardner Mr. Gardner on this. In terms of what Ohio might be doing, some states, because the Affordable Care Act gave them money to do it, have implemented programs where the insurance company has to justify a rate increase of more than 10%. So they have to show why they're increasing the premium. If it's more than 10%, they have to have a valid reason. I'm not sure what's happening.
And that's for Medicare supplemental insurance? Okay. Does that apply to any other Part D or no? Only Medicare supplement?
You know, I don't know the answer to that. Does anybody know for sure?
Okay.
Because I don't think Ohio's doing it.
Okay. Matt.
Okay, question here?
When you talk about that 80-20 rule for the insurance companies, number one, how do you know if your insurance company is not abiding by it so that you should get a rebate or refund? And if you do get that refund, when are you supposed to get it? And if you think you're supposed to get it and you don't get it, what do you do? So like 3 questions.
Very good.
I'll attempt to answer it. First of all, she's referring to Medicare Advantage plans. So that'd be the first thing. You'd have to have the Advantage plan. It is going to be audited. When you're supposed to get it, I don't know. That's a good question. If it's something you do want to know more about, give us a call. We'll try to guide you in the right direction.
So let me be clear. So if I am a Medicare consumer and I have the blue card with the white card with the blue stripe and the red stripe, this 80-20 rule and possibly receiving a reimbursement would not apply to me if my health care coverage is the Medicare card with the blue stripe and the red stripe. Is that correct?
As I understand it, yes.
Okay, thank you.
And I wouldn't expect this to be something where you will be getting a lot of refunds. This is more to keep the plans spending the money where they're supposed to be spending it. Does that make sense? The idea is not to put money back in people's pocket. The idea is to keep plans spending their money on what they're supposed to be spending their money on.
Okay, Matt.
Question over here.
Yeah, I read where several departments of insurance in different states are projecting increases in premiums. Has the Ohio Department of Insurance projected any increase in premiums for our Medicare supplement?
Increase in premium for Medicare supplements? Do you have a Medicare supplement? Have you ever gone a year where it didn't increase? I mean, I'm not just making a joke, but have you ever had a year where it didn't go up?
It goes up because the state is related, it goes up every year. So I mean, are they going to have an increase on top of that?
Remains to be seen. It's one of those things that I can't answer. I don't predict the future. They go up every year, right? You guys who have supplements, they go up every single year. They're private businesses, so they're able to go up. They're able to raise that limit. But I'm not going to predict the future saying what's going to happen.
Is there any projections for primary coverage for people going to the
Could you repeat the question?
Yeah, I didn't quite hear you, so.
Matt, can you take the microphone to the gentleman? He had a second half of his
If he
question.
yells,
I'm
I might
sorry.
be able to hear him, but.
Has Ohio Department of Insurance projected increases in primary insurance going up for people? If that's the fact, then the chances are the supplements should be going up also, wouldn't it?
And by primary insurance, do you mean someone purchasing private insurance, or are we talking about Medicare?
Yeah.
For purchasing private insurance?
Yeah, if they project on that, why wouldn't they project on the supplemental?
I see what you're saying, but yeah, that I can't answer. As far as I know, they haven't projected large increases, but I can't answer that 100% for you.
Is that something that the Department of Insurance does, though? I mean, do they put out a press release so the public
Not
can be
necessarily.
aware? Okay.
Not necessarily, and that's what it would be. It would be, you know, if they did a study and did a press release, but is that something that comes out, you know, every September 1? No.
Okay. All right, Matt.
Question? Okay.
This is kind of going back a little bit, but it seems like Medicare takes care of almost your whole body, except for your hearing. How's come? I mean, a lot of people need to hear, you know?
Okay. 3 things that Medicare at this point isn't covering. It's not covering regular vision, right? It's not covering your glasses, your contacts. It's not covering your hearing aids, and it's not covering your routine dental. Okay? It is going to cover injury or disease. Okay? So it's not going to pay for a vision exam, but if I need cataract surgery, I need glaucoma, it's going to cover that. Why doesn't it cover it? Just as I won't predict the future, I won't answer why. Elected officials who answer why. Well, let me put it to you this way, though. Once upon a time, they said that Medicare would never, ever cover prescription insurance. It would never cover prescription drugs. So we can't ever say never, right? But at this point in time, no, it doesn't cover it.
I just was wondering even part of it, because they are so expensive. And it's
I would agree with you.
Also,
And again, the whys go to the elected officials.
yeah. He's right there.
Federal, yes, let me correct that. The federal elected officials. Thank you.
Also, I have another question. You're always saying people would take care of themselves and get off the medicines and everything. Why don't they pay for partial of joining a Y or the gnomes or a gym of some kind? You know, even a partial.
That question to go to the federal elected officials.
Thank you.
I'll take a stab at answering part of that. Some insurance plans, I think wisely do pay towards that. There's, I think it's called Silver Sneakers, that a lot of people are participating in. I think it's a great idea for insurance to cover those sorts of services. And again, I think the reason Medicare hasn't covered certain things is a matter of cost and ideology and all kinds of things, you know, at the federal level. But you're right; those are good things for Medicare to cover.
There's a point that needs to be clarified for Medicare consumers. There is Part A insurance, which means it covers your cost while you're in the hospital, 80% of your cost while you're in the hospital. And then there is another part of your Medicare coverage which you can choose to buy or not choose to buy, and that's to cover when you go to see your doctor, you know, in the office, outpatient services, so to get blood work, to get physical therapy, that sort of thing. Would somebody speak to how Medicare Part B, which probably everybody should not be without if you're on traditional Medicare, how much is that going to be, how much will that cost in 2014? Does anybody know? That's the amount that's automatically deducted from your Social Security check if you want Medicare Part B.
At this point, no, we don't know what it's going to be for next year.
What is it today?
For this year, it is $104.90 a month. In 2012, it was $99.90. So it went up $5 from last year to this year.
And that's the amount that's automatically deducted from your Social Security retirement check?
For most people. For most people have it automatically deducted. Okay. Just to actually, not clarify, but just to tag on to something Sue said, she said that you can choose to take it or not take it. I just want to be clear. If you don't pick up Medicare B, if you don't pick it up, you will get a 10% penalty for every year you don't have it. So let's say at 65, I think the heck with this, I don't want it, and I wait 5 years and I pick it up at age 70, I'm going to get a 50% penalty tacked on to whatever the premium is when I turn 70. Guess when that penalty goes away?
Never.
Never, ever, ever. The only way to avoid it, to not pick up Part B, and not get that penalty, is if when I turn 65, either I'm working and I'm covered under my current employer, or my spouse is working and I'm covered under her current employer. Has to be a current employer. Somebody's got to be getting up and going to work.
So, John, how does, so you were talking about Medicaid paying for Part B. And so if that premium goes up and I'm on Medicaid, but I need my Medicare Part B paid for by the government, how is that changing in 2014, or isn't it?
So the good news, it's not changing. So
Okay.
The program is called a Qualified Medicare Beneficiary Program. It's for people whose income is below 100% of the federal poverty level,
Which
is about $12,000 a year,
Okay.
where the Medicaid program will pay your Part B premiums, and in addition to that, you will have, for your Medicare Part D, you will automatically be enrolled into a low-income subsidy Part D plan, and your premiums are much lower there, and your copays are drastically lower, only $1 or so for generic drugs and such.
And that's even with the two programs working together, how you were talking earlier, Medicare and Medicaid's working together, and what you just said applies. So for Erie County residents, probably in the month of May, we'll be getting a literature sent to our house if our income is $12,000 or less.
No, that's what I was trying to explain before. So for the program I just talked about, the Qualified Medicare Beneficiary Program, that is going on right now. That has been going on for years. There's no change. What I was saying, for a person who's only in that program, there's no change to them.
Thank you.
No change at all. But for those of you who currently are not enrolled, and you do have high costs for prescription drugs especially, I'm just saying that the program's out there, and it is something that you should look into. Go to your local county job and family services office, or actually you can go through OSHIP too. They'll help you out.
And so if you feel that you fall in that income bracket, a lower income bracket, and experiencing high medical costs, David has two of his colleagues who are OSHIP counselors that work out of Serving Our Seniors office. And so please know, if that's a concern for you, call either OSHIP or call Serving Our Seniors.
And another service you can apply for as well, you may not qualify for, for QMB, but another service you can apply for your Part D private drug plans is called Extra Help. It's through Social Security, so you can contact your local Social Security office or call the toll-free number for Social Security, and you can apply for Extra Help, which, as the name implies, gives you extra help towards your Part D premium and expenses.
And that's also a service we do at our office. Any of our senior advocate assistants can help with that as well. So if you're looking to afford Part D, please call Serving Our Seniors. Matt.
Yes, I've been on Social Security for 19 years, and it has been working well for me. But I have concerns with joining Medicaid. The problem that we're having with Medicaid is there's too many, I call them seagulls out there, that are too lazy to work. So they're sucking up and going on Medicaid. What does this group intend to do to weed out the seagulls? Thank you.
So let me rephrase that. Has healthcare reform done anything to change that make criteria more difficult to qualify for Medicaid?
So it's kind of a difficult question to answer from various reasons, but I will say this. I hear what you're saying. We're always worried first about fraud and abuse in the program. That's number one. So we're always looking through the program, trying to find individuals who fraudulently entered into the program. So that is something that we're always looking at. The other piece is that, remember, most of the expenditures that we have in the Medicaid program is for individuals who are elderly or disabled. That is where most of our expenditures are going. As a matter of fact, over 51% of our expenditures are going to those individuals. The second piece of that is currently in Ohio, to get on Medicaid, I think there's some things that people don't realize. We cover children to 200% of the federal poverty level, and I think a lot of you would say, okay, yes, we had to cover children. We cover parents of those children to 90% of the federal poverty level. We do not cover anybody else, and so right now in Ohio, we do not cover any person who is non-disabled and doesn't have a child that they are taking care of in their home. So if you're 54 years old and you have no children that you're taking care of at home, you cannot get on the Medicaid program in the state of Ohio currently. That is the rule. It's been like that. That's not a change. That is the way the program currently works. So to your question of, well, we want to get individuals off of the program. Yes, I've been working on that quite a bit with the governor. How do we get individuals off of the program? And one of the ways to do that is to deliver to them high quality health care, right? So we have individuals who are on the program who, if they didn't have that, they would just get worse and worse. And so it's how do we improve their health outcomes. I also want to make it clear that with the Medicaid program, we don't hand out checks to people. And so that's one of the things that people think of, well, you're on Medicaid, you're getting this money. You're not getting any money. It's when you go to a physician's office, when you go to and I'll look down the aisle here, to the hospital, to the health center, right, into the emergency room, which we'd prefer you not go into the emergency room actually, and go see your primary care physician first. We are putting things in place to make sure that individuals are getting the high quality care that they need. We also work very closely with the County Department of Job and Family Services, with the work requirements for the other programs there to make sure that's happening. The goal of Governor Kasich is bring jobs to Ohio, right? What's going to get people off the program, number one, is making sure that there's jobs for people in Ohio. That's what he's been focused on. We've been focused on that also in the Medicaid program. We've actually, through some changes in the Medicaid program with our managed care contracts, we brought over 2,000 jobs to the state of Ohio by doing a few simple things like saying that the call centers for our managed care plans need to be in the state of Ohio, which we didn't have that before. I put that in there, and guess what? Illinois lost their call center, and moved to the state of Ohio because that's where, it had to come. So we've been working on that too. So we hear what you're saying. We agree with what you're saying to make sure that the program's only for individuals who qualify. And how do we make sure that those individuals can move up and off the program? So right now we have about 2.4, just so you understand, we have about 2.3 million people in the program. About 1.1 to 1.2 million of those individuals are children. So the number of parents we have on the program is actually fairly small, because then the rest of the program is mostly individuals with who are elderly or disabled. So I just wanted to make sure that people understand that right now in the Medicaid program, that's what we're looking at. Now, Senator, hold on just a second. Senator Gardner was giving me the John, but.
Well, and let me say that I don't want this to turn into a Medicaid forum. If your information has to do with how Medicaid relates to health care reform, I would like you to elaborate, but if it's about talking about children and parents and coverage, it's off track, and I'd like to stay on track.
The only thing I would say, and maybe the director doesn't want to say this, but there is more focus now on Medicaid and some of the issues of efficiencies, and focused on making sure the needs are met and make sure we maintain appropriate access. And we've done that in part because we've established a new Department of Medicaid. It is now, it used to be part of a more mega Department of Jobs and Family Services, and this is more focused now. So at least, sir, I think your concerns have a better chance to get addressed because of the decision that was made to focus and have a specific Department of Medicaid with a director who's specifically in charge of that function of healthcare. Is that fair?
Yeah, so let me just point out one thing that gets to this, and I think to the gentleman's point is, the Medicaid expenditures in the state of Ohio, we're growing somewhere between 7 and 10% a year. Since Governor Kasich has took office, and myself and Director Moody of the Office of Health Transformation, we kept growth at about 3% or less a year. So some of the reforms we put in. The importance of that is it helps us do these other things to make sure that health care is there for all of you. We have no waiting list for our passport programs and many of the home and community-based programs to help individuals to stay at home. So we are working on that.
Thank you. Matt.
What effect, if any, will the health care program have for us military veterans who do get some benefits from the VA? Is there anything that will affect us now?
Good question. So will healthcare reform affect veterans' benefits?
No. If you're a veteran, excuse me, if you're a veteran and you're getting care through the VA, you can continue to still get care through the VA. If you're a veteran who's a military retiree and you get your benefits through TRICARE, you can still continue to get your benefits through TRICARE.
Is it going to cost more? Will it cost the veteran more?
It shouldn't cost any different than it currently does.
Okay.
So I do want to add one other piece to that. We have found a number of veterans who are enrolled in the Medicaid program who actually are not taking advantage of their veterans benefits. Many of those individuals are in nursing homes. So we have started with the Ohio Veterans Administration a program to start identifying those individuals, doing outreach through the county veterans administrations to reach out to make sure that we help veterans in those situations get enrolled into the veteran program to be able to access the veteran services. Just started that. I mean, so small that we've identified 10 people in Cuyahoga County. That's where we're starting at. There's many, many more than that. The reason we're doing that is, again, improve health outcomes, making sure people get the services they need, but it also reduces our Medicaid expenditures, and so we can make sure that the program can be up and running.
So, John, was that because of healthcare reform that you took on that initiative? Is that all part of not duplicating service and putting people in?
Indirectly, because healthcare reform does have impacts on the Medicaid program and some of our costs we're raising, so we looked at where can we do efficiencies, and this was one of the areas.
Nice job. Nice job. Okay. Question.
Yeah, I don't know if this question is on track, Sue, but you can tell me once I ask it.
Okay.
An incident with my mother, she was ill, so when she went to the doctor, they ordered x-rays. And then when the results of the x-rays came back, the doctor said, well, you know, it's not detailed enough, so we need to do an MRI. So my question was why didn't they do an MRI right away? Because the doctor knew it wasn't going to be in detail. And I was upset because I was told that because Medicare says you got to do an x-ray before you do an MRI. And then my concern was, well, now that's more cost to Medicare's getting involved in, and then I was concerned that, you know, that's going to maybe put her in the donut hole, you know, or you know, and she gets into that every once in a while, or she has to do that. So, you know, why, you know, and they just said that's what Medicare demands, is you take these tests before you do that, even though they knew it wasn't going to be detailed enough.
I can't speak to this specific case here, but there are certain things where there is a certain, essentially it's a medical protocol. We do this test before we do that test. With Medicare, though, always keep in mind two things. There's an exception for everything, and everything can be appealed. Okay? Now, so that, I know that's a very general way to answer that. There's an exception for everything, and everything can be appealed. To answer the second part of that about the donut hole, the coverage gap only refers to your prescription drug insurance. Only refers to your Part D. Has nothing to do with hospitalization, doctor's visits, skilled nursing, hospice, anything like that. None of that has anything to do with the donut hole. The donut hole is specifically to do with your prescription drug insurance.
But to her question about, so that too is another concern that Medicare and Medicaid consumers have is do I have to go through a chain of process, and And will healthcare reform keep my doctor from making decisions that really would be in my best interest as a patient? So she's had an example before healthcare reform has been implemented. So is there anything brewing that we ought to understand, that there's a process we're going to see our doctors follow rather than looking at me as a patient and treating me the way the doctor wants to treat me?
I personally would say no to that. This kind of thing's been going on for quite some time, and the hospital does their best to work through those, and the hospital usually is the one that sees that first, because what would happen is when we send in like the MRI test, we would get that denied, and then they will ask us certain questions. What did you do, what was done for this patient prior to this MRI? We go ahead and we send all that information in. We'll write an appeal. In the event that we don't have enough information in-house for that, we will turn to the patient's provider to get that covered. So I think it's just care to make sure that you're looking at the patient and their care prior to doing things like MRIs and CT scans right off the bat. So,
because MRIs and CT scans are high-cost procedures?
Yes, they were high-cost procedures. Yes. Mm-hmm.
Okay. Okay, I have a question here.
Is there any truth to the rumor that with the new health care, there will be an age limit on hip or knee replacements of 70, 75?
There's no truth to that. Again, it's strictly based on the recommendation of the physicians, working. But like I mentioned before, there's no rationing. So again, if you're an appropriate candidate for that, based on your health, you'll have that replacement, and that should be covered.
No matter what age?
Regardless of what age, right.
So are a lot of you hearing in the audience, are a lot of you hearing that based on age, it's going to determine what kind of care? How many are hearing that based on my age is going to dictate how much care I do or do not receive? Okay. So that being said, are there any words of wisdom that you would want to share in addition to what's already been said that these folks need to understand will affect them in 2014? Because they believe their age is going to dictate their care.
I think it can't be said often enough. There's no rationing. There's no death panels. There's nothing that's going to stop you from seeing your own doctor or keeping the health care that you have right now if that's what you choose to do. And I know it's easier said than believed, but it is in fact the truth.
We have a question over here. Looking at the quality pieces, KeyPro has been around for a very long time. Is KeyPro's role changing at all with the Affordable Care Act?
KeyPro's role is not changing at all.
And can you share with the group what some of the things you're looking at? The gentleman from Medicaid said there's no way of checking nursing homes. Well, we know there is. We know they're surveyed and so on and so forth. So can you share some of the things that you do?
Well, the nursing home survey is done through the Ohio Department of Health. But what Ohio KeyPro does is twofold. One is we work with providers with their quality initiatives, and the other is we perform appeals for patients who are feeling that they're being discharged too soon from any setting. And we perform quality of care complaints directly from the people receiving the care, Medicare beneficiaries. And there are some websites out there that you can compare home health agencies, and you can compare nursing homes and hospitals. They're called Hospital Compare, Nursing Home Compare, Home Health Compare, and they can be accessed through Ohio KeyPro's website, which is ohiokeypro.com. If you don't have internet access, you can call us and we can mail you the information that's on the website.
Okay, question?
Entering January 1st of 2014 with a pre-existing condition, should we be concerned about a monetary cap for treatment?
No, That's a really good question. No. In some instances, it's already true. But beginning in 2014, there's no denial of coverage for pre-existing conditions. People can't be turned away from an insurance plan because of a pre-existing condition. And it already exists for people on Medicare, and it will be true for everyone, that there are no lifetime limits and no yearly caps.
There was Senator Gardner? Okay.
In this, again, I revert back to the fact that with all due respect to Washington, I don't necessarily trust how this plan is going to, this act is going to roll out over the next few years. The one thing that is a challenging, it's challenging to answer the question about whether you can always keep your own doctor or your own plan, because in some cases your doctor and your plan are not going to be part of the system. There's no requirement that the plans stay in, for example, stay in existence in Ohio and provide the coverage. So therefore you may be required to have a different plan because that plan chooses not to do business in Ohio. So while I think it is fair to say, as long as your plan is in existence and your physician stays as part of that, for example, those on Medicaid, there are some questions and concerns about medical access because physicians don't have to participate in Medicaid. I've worked on issues with, especially in the dental area for years, about Medicaid reimbursements being low enough that very few dentists participate. And so that became an access issue for health care for the poor in the dental area. So I think the thing that will be interesting to see is whether physicians and whether health plans, how many of them stay in the market, and therefore you're protected by maintaining that same level of coverage and care that you prefer. I don't think there's anything in the Act that says, no, you can't and you're out. So I think that's fair to say, but I do think there are, I would candidly say that it would not be inappropriate to have at least some degree of anxiety over the next year or two or three as plans come and go, or as those stay in the market to provide coverage.
So just to clarify, so you're talking about Medicaid.
No, I'm talking.
You're talking about Medicare?
I'm talking about the Affordable Care Act itself.
Okay.
And as it relates to the gamut of health care coverage, it is not as if you've got a private, for example, a private health insurer, there is no requirement that health insurer continue to provide insurance for you for the rest of your life. I mean, and so therefore there may be changes to your plan and to the providers that you are able to access based on those decisions. So I think to say, with all due respect, to say that we know that in 2 or 3 years you're going to be able to keep your same doctor and have your same health plan under this new system may or may not be true, depending on your own specific circumstance. I hope that's a fair depiction and analysis. I just think I think that needs to be said, and I think if it's not accurate, someone on the panel can challenge the accuracy of what I just said.
So let me see if I understood your remarks. So if a physician is saying that health care plan, that insurance plan, if you're on Medicare or Medicaid, is not reimbursing me enough, I don't have to take that insurance plan as my reimbursement. Did I understand that correctly?
I would say that I can't speak to that on Medicare because that's federal.
Okay.
And I just don't deal with Medicare.
Okay.
But on the Medicaid side, I know there have been access issues depending on reimbursement rates and other things. And
Okay.
some physicians and some other providers prefer not to deal with the Medicaid issues.
Right.
They just don't. And
Right.
I'm not making a judgment call there, but some of them don't. I had a pediatric dentist in Bowling Green who was a champion in the whole state for taking care of pediatric Medicaid children, and people came out an hour and a half just to see him because it was that difficult. And some people are concerned that there may be, over the next couple of years, more access issues based on reimbursement rates and ways to make this act affordable.
And I am glad you brought that up, Senator, because that is the other concern that we often hear is with healthcare reform, what's going to happen is there are fewer doctors who will accept Medicaid, and that means I will lose my doctor, or there are fewer people who will accept Medicare reimbursement, And it's all because of healthcare reform that this is going to happen. So here's, if any of you can address this. First of all, if healthcare reform were not to happen and we just kept doing business the way we've been doing business with traditional Medicare and Medicaid, would we be in the same pickle?
Maybe I could I'm sorry,
Well,
Senator.
since I raised that, I believe the fair answer would be we've always had to some degree access challenges, reimbursement rate challenges. So I do not lay all of that on the Affordable Care Act. I think it adds some additional questions to the table, but I think it would be unfair to lay all of that because we've had, as I said, we've had access issues and reimbursement rate issues for a long, long time.
Okay, so if we did nothing and did no healthcare reform, these problems have existed in the past, and we don't know if they would be worse in the future or would have stayed the same. We don't know that, but these have always been existing problems. So then the question is healthcare reform making these access issues better or worse?
I think, Sue, first of all, I wouldn't disagree with Senator Gardner's comments. We really don't know, but I can tell you at Firelands, our mission as part of the dedication to the community is to have that integrated model. And that includes not only our acute care facility, but obviously ancillary services, dialysis, home health, but also growing of the Firelands Physician Group and including our urgent care out at Strub Road. We've opened it at Vermilion, and we have another one that we're in the process of constructing down in Clyde, Ohio. All people that are Medicaid eligible are served at those facilities. All physicians that are part of the Firelands Physician Group are served by Medicaid. So the point is that we're trying to respond, and again, through the integration model of trying as a group and have that economy of scale, be able to deliver that service regardless of what plan you're currently on, including Medicaid. So, but there always has been an access problem, and again, doctors can opt out of participating in Medicaid, but if you're a Firelands Physician Group member, we accept Medicaid patients.
Okay, and to speak to the dental, this is unique to Erie County. For those of you who are on Medicaid and cannot find a dentist, recently the Erie County Health Department opened up a dental clinic, and they are seeking Medicaid consumers. They want Medicaid consumers because they know they're traveling to Bowling Green. And you don't have to do that if Medicaid is your dental insurance. So.
And on the Medicare side, the physician reimbursement on the Medicare side is actually separate from the Affordable Care Act. That's from different legislation that was passed in the early 2000s that reimburses physicians reduces the reimbursement to physicians on a certain scale. And every year, physicians have thus far successfully sought to roll back those reductions, and so I don't know whether that will continue or not, but that is separate from the Affordable Care Act. That's something that was passed, as I said, actually I think it was 2003, but it was in the early 2000s, and it deals with specifically physician reimbursement under Medicare.
So I just want to emphasize this because we do have people in the audience who are on Medicaid and Medicare, and you're saying that the reimbursement of Medicaid is not related to the healthcare reform that's being implemented?
I don't know about Medicaid because that's the state, but the reimbursement of Medicare is not related to the Affordable Care Act. It's related to different legislation. Although I guess, actually I should, without getting too complicated, physicians will get incentives for quality care, and they will get dinged for not quality care. So, and that is under the Affordable Care Act. So without getting really technical about it, but this reimbursement question, where I know that it's been the case in some physicians' offices, they post a sign and they'll say, call your congresspeople because if we don't get reimbursed at a particular rate, we're going to stop seeing Medicare patients. That's a separate piece of legislation.
And that's not part of healthcare reform in okay,
Right.
So thank you, that's new to me. And I saw a question here.
If my physician notifies me that he'll no longer accept reimbursement from the government for my health care, do I have the ability to pay part of that out of my pocket and still continue to have him as my physician?
So with healthcare reform, if his doctor decides I'm not taking Medicare anymore, or I'm not taking Medicaid anymore, if this patient can pay out of his pocket, can he keep his physician? Can I hear a verbal from anybody?
The short answer there is as long as the physician agrees to it, sure. Any physician's obviously able to what we call private contract, basically meaning if they're willing to let you private pay, it's going to be on a physician by physician basis though.
So
most of us, I'm old enough myself to remember, my mom taking me to the doctor and paying cash at the counter. But it seems like now nobody does that anymore, but that's going to be on a case-by-case basis.
So has anybody heard that that's not what you're asking?
If my physician says that he's only going to get reimbursed $45 for this service, and he expects to be reimbursed $75, can I, as a consumer, allow the government to pay the $45 and me pay the additional $30?
Go ahead, Jane.
No. When they're in the Medicare program, they have to accept Medicare's contractual allowance. So they cannot balance bill you for that. And just because of the goodness of your heart, you really liked what he did for you and you want to pay it, he cannot accept that. And another thing that I wanted to say is, as far as if you want to pay for if you have a physician that's not in the Medicare program and you still want to go to them and you still want to pay them, they cannot order your tests at a facility. They cannot order diagnostic lab, diagnostic radiology, or admit you to the hospital. So that's another thing that you need to understand about that.
Is that before healthcare reform? Is that how it's always been, or is that new? It's always been. Mm-hmm. It's always been that way? Mm-hmm. So if you have a physician that he never accepted Medicare, but you wanted to do business with that physician, so you paid him out of your pocket, he couldn't follow you to the hospital?
Correct.
Okay, and that's how it's always been.
That's how it's always
You had to have privileges to see patients in hospitals. Okay.
Question here?
I have a quick question. I work at Serving Our Seniors, so of course I look a little young to be asking this question, because I think Medicare will probably not be around when I retire. I don't know. We work, obviously, I think I understand Medicare sometimes better than my own health insurance, so if you could briefly explain the difference between original Medicare and Medicare Advantage. Last panel we had here, somebody mentioned how healthcare reform was going to affect some of the Medicare Advantage plans. And I know a lot of public employees that are retired, have PERS, or state teachers, they do have Advantage plans. So if you could just briefly explain if you know it's going to affect the Advantage plans and how the Advantage plans are different from original Medicare. So.
Okay. If I really wanted to explain it, that would be day 4 of our training. So we won't do that. But let me tell you that the easiest way to explain Advantage plans is it's an alternative to original Medicare. So if I'm eligible for Medicare, I get my A and my B. And with A and B, with A is my hospital insurance. I have deductibles when I go into a hospital, when I go into skilled nursing. With B, I have an annual deductible I meet of $147, and after that, it's going to pay 80/20. Meaning Medicare is going to pay 80%, I'm going to be left with that remaining 20. Or I can choose to join an Advantage plan. And what I'm doing when I join an Advantage plan is this private company now, who's contracted through Medicare, is now assuming my medical responsibilities. I'm still paying my Part B premium because I still have A and B. I still have all the rights and all the protections I had under A and B. It's now just being handled through this private company. That's an Advantage plan. The second and third parts of your question there is, do we see a lot of changes coming? That's one of those, remains to be seen. As of, next year, 85% of the funds that they get from Medicare, meaning that $104.90 that I pay for my Part B, if I have an Advantage plan, part of that money is going to pay my premium for my Advantage plan. The money that they're receiving from Medicare, they have to spend that on patient care. They have to spend it on medical care. How's that going to affect the plans? Let's wait and see. What we saw a lot of for this year were some plans that a year ago, some plans that in 2012 were perhaps a zero premium plan, had added a premium. And the most they could add was $36. So there was one plan in particular that I'm thinking of that, it was zero premium in 2012. In 2013, it was $36. That was the most they could add. The most they can add for next year is $30 on top of that. So that plan that in 2012 was 0, 2013 is 36. There's a possibility that in 2013 it'd be $66 a month. So still not bad. When you compare it to a supplement plan, it's still definitely affordable. The question was about some of the plans like the PERS and the STRS, which is State Teachers Retirement System, Public Employee Retirement System, things like that. Those, even though they are Advantage plans and they're through some of the same companies, they are private plans. It's a private plan, meaning I can't join the State Teachers Retirement System because I'm not a teacher. And I never was a teacher, so I can't get on there. So each of those are going to be affected a little bit differently. I don't see them necessarily being affected by the Affordable Care Act because it's not a public plan. It's a private plan through those systems. And it is state, it's not federal.
I have a question here.
Actually, I have two questions. Are you saying if you have the Advantage plan in comparison with a supplemental plan, that the Advantage plan is that much lower than we have ARP? Okay. Jim and I pay $405 a month. Are you saying that if we had the Advantage plan, it would be a lot less?
There's one question. You want me to answer one question at a time?
Yeah, and then I have another one.
Now, back up a little bit. We're talking about money up front here. Mm-hmm. What you're paying is actually state average. State average is about $200 a person for a supplemental plan. Mm-hmm. So that 405, I heard a couple people gasp. It's, 203 a piece. That's actually a state average there. The difference being this, and really y'all should take my volunteer training. You'd know all this. The big difference being this, a supplemental plan, you're paying up front. Meaning, I'm going to use you as my example, she's paying that $200 for herself up front, knowing that it's going to cover all the bills that Medicare doesn't cover with the exception of prescriptions. And I'm assuming you have a Part D plan on top of that.
Yeah.
Yep. It's going to cover everything, more than likely, depending on what plan she has, at 100%. Meaning, if she goes into the hospital, she spends, 3-4 days in the hospital, goes to a skilled nursing, spends 2 or 3 months in a skilled nursing, she's going to come out of there with no bill because she paid it up front in her premium. Thank you. The Advantage plans have much lower premiums, significantly lower premiums. Reason being, you have a copay every time you use it. Okay, you go to the doctor, you have a certain copay. You go to a specialist, you have a certain copay. You go to the hospital, you're going to have a daily copay. You go to skilled nursing, you're going to have a daily copay, so on and so forth. So it's the difference between the two plans are, think of it as if I have original A and B with the supplement, I'm paying up front. I'm paying up front, and I know at the beginning of the year what my medical expenses are going to be. Okay, with the Advantage plan, I'm going to pay as I go. I'm not paying a lot up front, but I'm paying as I go.
And just to clarify, this has been in place and this is not part of healthcare reform. So it's really important that when you hear this dialogue about traditional Medicare and Medicare Advantage plans, Medicare Advantage plans are not because of the Affordable Care Act. So that's just something that's existed and it's not changing in 2014. Matt.
I guess it's a two-part question. As more and more people get on Medicare in 2014, and some people, we all age differently. Some people, through no fault of their own, have much more health care. I hear people talking that the person who's healthy and may get to age 80 with very little health care is still going to have their premiums heightened to balance the scale for the people who have had more health care. So I think that question is philosophically, has that been thought about? Is there a proportion to that? Will it just be across the board for the person who's had less health care through Medicare?
Good
paying
question.
A premium? And then let me just spin that one more time. Next year, people who are on the, as you call it, the traditional red and white card, or red and blue, whatever it is, card, do they have to join the MyCare or My Ohio Care? I mean, is Medicare still a separate thing from My Ohio Care? So those are my two questions. Thank you.
I'll answer the second one first. If you're just in Medicare, you're not enrolled in Medicaid, then nothing changes for you. So MyCare Ohio is only for individuals enrolled in both Medicare and Medicaid. So if you're just Medicare only, it does not apply to you. So I wanted to clarify that one. To the first question, that's luckily not a Medicaid question.
First question is an easy one, though. The question was, are premiums going to go up for folks who have used more health services, who have, for lack of a better way to put it, who are unhealthy and use more services? And the easy answer there is no. No. The Part B premium's the same for everybody. The only way you're paying more is if you're getting a penalty or if you're making a heck of a lot of money and you get that income adjustment. The same way with the Part D, the same way with an Advantage. The one difference might be with the supplemental plan is when you sign up for the plan. Okay, if I sign up when I first turn 65, I'm good to go. If I wait until I have a major health crisis, if I wait until I have chronic conditions, a major health crisis, I go to sign up for the plan then, well, guess what? That's a private company, and they're going to want to know my health history, and they can adjust my insurance rates based on my health. They only adjust rates in one direction, right? But once I'm on that plan, they're not going to jack it up year by year based on my personal health history. If they're raising the rates year to year, they're raising them across the board. Now, will it by the number of claims? Probably, because that's the same way all insurance works. You know how they, when your homeowner's insurance goes up and they say it's because of the hurricane? And you said, I'm pretty sure there was no hurricane that came through Ohio last year? Same sort of thing.
So what I'm hearing a common theme here, that there is concern that come 2014, I may not be able to see the doctor or go to the hospital that I want to go to. So I guess I would like you all to say, is that true or is that not true for 2014? Respecting Senator Gardner's point that he is not going to say that access is not going to be an issue. But for 2014, when healthcare reform kicks in, does this audience have reason to be planning for an alternative hospital or an alternative physician? Anybody want to answer a yes or a no?
I'll say no. I mean, you can continue, or you can expect anyway, to continue that your Medicare is going to cover what it's supposed to be covering. And if you're on Medicaid, I can't really speak to the state, but I assume it will, continue to cover, and in that integrated care model will cover, I think, more efficiently and more effectively in some fashion. And one thing that the Affordable Care Act does, which was alluded to earlier, is that it promotes and encourages this idea of an integrated delivery system. So, for example, you're not going to your primary care doctor and he's giving you Celebrex for your back pain, and you go to the kidney doctor and he says, oh my God, you should never be taking Celebrex when you're in kidney failure. You have to get off that right now. One of the goals of the Affordable Care Act is so that all of your providers are working together to deliver those services well. So to answer the question, I would say no. You should not see, suddenly be reassigned to the Toledo Hospital or the Cleveland Clinic rather than going to Firelands.
So, and the question that this gentleman had about cost, I think I've read some articles too that women premiums are higher than men's insurance premiums, and will healthcare reform change that so that now older people, both men and women, are paying more?
No, in fact, one of the other things the Affordable Care Act does is to say that you cannot charge more money for age, for issue, which is an illness or disability, for gender, occupation or geography. They can charge more money if you smoke. And there will be, I expect, higher premiums for people who smoke, but they cannot charge more money as they have in the past. Rather, they have to be based on community rating.
So the article I was reading was that there's actually being a shift in cost for premiums so that actually younger people are the cheapest right now, are the cheapest to insure. A 20-something is cheaper to insure than a 70 or 80-year-old, and that's going to shift, that it's going to be more expensive to insure a 20-some-year-old. and the price of the premium for the older person will drop. Is there any truth to that?
Well,
As part of leveling the...
I'm not an insurance expert. Maybe the Department of Insurance person can speak better to it. But when insurance is based on community rating, insurance anyway is based on, an average. For example, paying higher home insurance because they had a hurricane down south. So I can't say that a person who is 20 years old who needs insurance is going to be able to pay as cheaply as they do now. I don't know. I can't really answer that question because I think it's just how the insurance marketplace works.
Well, as a provider, one of the challenges we have when we negotiate with our third-party payers is what we call divide and conquer, because what the insurance company wants to do is divide and make those pools as small as possible, because then they can maximize those premiums. If you get a larger pool that has both healthy and maybe people that have some healthcare issues, but you can make that pool even bigger, then in turn, in theory and in practice, if it's done properly, that cost should come down for everybody. And so, a good example was just in the hospital itself, we had a self-insurance plan for all of our employees. I mentioned we also have a Firelands Physician Group. Well, technically, it's a separate corporation, but finally, our third-party administrator, Medical Mutual, agreed to let us pull everybody together. And guess what? The rates went down for all of our employees, including the folks at Firelands Physician Group. So again, as a provider, we encourage, larger pools, larger groups, because that way it then spreads out those risks that are associated with insurance and insurance coverage.
Okay. Thank you.
And you asked us to kind of stay on the Medicare or Medicaid topics, and I will jump in here for a second. And we work very closely with the Lieutenant Governor, who's also the head of Department of Insurance. Your question that you're bringing up really has more to do with private insurance and the exchanges and where it's at. And so I will just touch on that briefly, because this is not necessarily a Medicare issue. It could be a Medicare supplement issue, but it's not necessarily a Medicare issue. And then I will tell you, it's not a Medicaid issue. So this is not a Medicaid issue. But the Department of Insurance, if you go to their website, they do have some information that's been put out. The governor's talked about it. The lieutenant governor's talked about it. The state of Ohio, currently, before the Affordable Health Care Act, insurers could, when they offered a product, could have a lot of different products that they offered, different benefit plans, and they could rate on many different topics. So whether you're a smoker, whether you're a man versus woman, your age, anything basically they wanted that they could do. So that's why the Ohio insurance market is very, very diverse. The Affordable Care Act actually does come into the state of Ohio and say, if you're going to offer private insurance, you can't rate on all those different factors anymore. And as a matter of fact, here is what is now the limit of, or the floor on benefits, which is called the essential health benefits. So if I was currently in the state of Ohio and I'm 23 years old and I need the private insurance, this is private insurance, individual market, I could go out and find a plan where, I'm a healthy person, so all I really want to pay for is hospitalization with a $5,000 deductible, and I never go to the doctor, so I'm not going to pay for that. So you could choose to find a plan to do that, and it's going to have a really low premium. But if insurance, right, is like your car insurance, if that person actually has something go catastrophically wrong, that plan may or may not cover those things, and so that's a whole nother issue. What the Affordable Care Act does is says everyone's got to get at least these essential health benefits. And so what does that do? If you're going to be paying for things that you necessarily in the state of Ohio weren't paying for before. So in the state of Ohio, their question came up earlier, is our premiums going up? On the private insurance market for individuals purchasing insurance, the assumption is it is going to go up. Now, I am not going to get in the debate about whether that's good or bad or what's in there, because you could get more and all that, but it is planning to go up. But again, those are not direct Medicare issues. That is not impacting your Part A or your Part B or your Part D. That is for private insurance.
Thank you. What? Oh, go ahead.
Go ahead. Randy, you mentioned earlier, you used the word anxious earlier. I'm a evangelical, I'm a conservative. I'm a Republican. We all know who's going to be administering this program. I guess you'd say I'm anxious too, but I don't know why. It's not really a question. I just want you to take that message back to, not you, but I want you to take that message back to Washington.
I think that's a really good point. I think that I hear that a lot, is that I'm concerned and I'm anxious and I don't know why. And when you don't know what you don't know, you feel like you're in limbo. And there's nothing that causes you to feel more wary than when you're in limbo. I'd rather have bad news. Tell me my premiums are going up. Tell me my care is going to be rationed, but don't leave me in limbo. I can deal with information. I can't deal with being in limbo. And I think the feedback that everybody's hearing here is that my premiums are going up, I may lose my doctor, I can't use the local hospital, and I probably, because I'm 75, won't receive cancer treatment because I'm that age. And I hope, if nothing else, we did a really good job getting this panel to answer for you those questions. Because if we didn't, I missed the boat. And I don't want to miss the boat on that. Okay. And we have a question here.
Is it true that some states are not going to join the Affordable Care Act?
Oh, very good question.
So this is one of those very difficult questions to answer. The Affordable Care Act has many, many pieces to it. There are certain things that states can elect to do or not do. And so when you say, is a state going to join the Affordable Care Act, the governor and the lieutenant governor has been speaking out about how they feel that Obamacare is not the right thing for the state of Ohio. When they're talking about that, they're talking about the regulation of the private insurance market. And so as a state, what we have decided to do, there's a couple of things that we can or can't do. So one of the pieces is, what you're going to talk about next forum, is whether or not there is going to be a private insurance exchange in the state of Ohio. The governor has just chosen not to have the state run that insurance exchange. There will be an exchange by the law. Every state is going to have an exchange, but the state of Ohio, it's going to be run by the federal government. So they will be setting up the system. Now in that system, there's two other decisions that have to be made. Who will regulate the insurance companies in that exchange? The state of Ohio decided that the Department of Insurance would continue the regulation of those insurance plans in the exchange. The other question was, who would make the determinations of whether or not the person is Medicaid eligible? We chose that the state would continue to make that determination. So there will be an exchange out there running that's going to be run by the federal government, but I will be making the decisions around whether a person is eligible or not eligible for Medicaid, and the Department of Insurance will be regulating the insurance plans on the exchange. The other big piece of that is whether or not to expand the Medicaid program. The Affordable Care Act had a requirement in there that all states had to expand the Medicaid program to all individuals up to 133% of the federal poverty level. The governor did put in the budget to propose to cover those individuals. In the budget, that was not passed. And so that's not in there. And so we're currently working with the legislature on what the state is going to do with that. So back to your question, original question is, can a state opt out of the ACA? You can't opt out of every part of it. We can't say, oh no, we're not going to run an exchange, because the federal government will be running an exchange in the state of Ohio. There are pieces of it that will be happening one way or the other. The question is about the different pieces of what is the state going to do or not do. There are states who have rejected the Medicaid expansion, and as we did with the exchange, that we're not going to run it. So
we're going to have to wind down. We've got about 2 minutes left. But can you share with us, what is, if Ohio does expand Medicare? I mean, is that still on the table? Is that a possibility?
Well, that would be Medicaid.
Medicaid expanding, okay. And what would your income need to be to qualify for insurance under Medicaid if it is expanded?
So, if it is still a possibility, Senator Gardner was just asking me about this, of what I've been hearing. I've been talking to various senators and representatives on first doing Medicaid reform and then possibly looking at expansion. The governor has said he wants to see it happen. For a family of 4, we're looking at those individuals making less than $24,000 a year. So that's what we're looking at. And I want to make it clear that when we looked at the individuals who possibly would be covered, it's about 375,000 individuals in the state of Ohio. Over half of them have income, and thus they work. So they are individuals who are working. About half of them are working, but they have either can't afford health care insurance or none is offered. So that is one of the pieces out there of that they would actually be covered. And so it's still up in the air. There is no deadline to this. January 1st is when it starts. We would like to turn it on January 1st because the federal government pays 100% of the cost for the first 3 years. It's then phased down to 90%. And so, as the governor has said, it's going to bring, in the first year, about $2 billion into the state to help those individuals who need health care and make sure that they get that. So it's still up in the air, more to come. We'll be working with our legislative partners to see what happens with that.
Great. And the Center for Budget, Center on Budget and Policy Priorities determined in each state how Medicaid expansion would work in those states. And in Ohio, there are currently 705,000 uninsured adults who would be eligible for Medicaid if the state expanded its Medicaid program. Of these, 578,000 people would be newly eligible for Medicaid under Medicaid expansion, while 127,000 are people who are currently eligible who are not enrolled. And the reason I bring that up is because there are people who qualify for Medicaid now who don't know it, and I would encourage you, if you have questions, either to contact OSHIP or to contact Serving Our Seniors, because there are people who qualify for not only Medicaid, but QMB, for even sometimes for Passport, and you don't know that you do.
Okay, we're going to have to wrap it up. Before we do, my coworkers, would you do me the favor of standing, unless you returned to the office, did you? My coworkers, the senior advocate assistants, the senior advocate is running the camera in the back, if you'd wave, Anthony. They are a wealth of information, and they can help you troubleshoot anything that is overwhelming for you as it relates to Medicare and Medicaid. Their area of expertise is Medicare Part D, which is the drug coverage. We also are blessed to have a wonderful partnership with OSHIP, and we have 2 volunteers. Patty, would you please stand, and Bill, would you stand? They have been trained by the Ohio Senior Health Insurance Information Program. They volunteer their time to provide Medicare counseling, and they do work out of Serving Our Seniors office. And if you have any questions about your explanation of benefits, they would be a great resource to use. Just call our office and we will work with you to book an appointment. And on behalf of everybody here, I would like to thank each and every panelist for making time to help relieve our fears, make us better informed, and Senator, thank you for not mincing any words and keeping us in the realm of reality, because we always get a little suspicious when everything sounds a little bit too good to be true. So thank you so much for everyone, for your information, your time, and your expertise. And finally, Matt, thank you so much for your facilitation. Thank you for the support of the Sandusky Register. It's my favorite newspaper, if you can wonder why. And thank you. You do a wonderful service to the community. Thanks very much. Thank you all for being here.